Good evening, everyone. As part of the initiative from the Department of Medicine, MS Ramaya Medical College, Bangalore, on a basic module on deciphering the ECG, we would like to present a summary of the previous session that we had so that it enables us to revise for the subsequent class. So we'll be covering the entire revision of the entire class under these headings. So coming to the understanding the electrophysiology of the heart. So we know that the heart has its property called as automaticity, that is because of the pacemaker potential generated by the SA node. From the SA node, the impulse activates the right atrium and the left atrium via the internodal tracts and reaches the AV node where there is going to be a physiological delay. This physiological delay helps the ventricle get filled with enough blood so that there is adequate amount of contraction in the next cycle. And in case the SA node fails, then there are the backup called as latent pacemakers, which are the AV node, the Purkinje fibers, and the ventricular myocardium that can generate impulse on its own at a slower rate. So once the impulse reaches the AV node, it subsequently is going to divide into two major highways that are going to activate the right and the left side of the heart by the right bundle branch and the left bundle branch. This left bundle branch has three fascicles, namely the septal fascicle, the anterior and the posterior fascicle. And the right bundle branch is going to divide into a superior, the middle, and the inferior fascicle. And this is going to be through a rapid conduction system called as the Purkinje fibers that conduct very quickly at 4 meters per second. So any activation of the heart below the His system is going to be very rapid. So all this is going to have a ionic basis for it. And why is this ionic basis important? Let's understand. So this pacemaker potential is by a funny current called as IF current. It's funny because it gets activated during repolarization, and the blocker for this called as ivabradine is approved drug for heart failure as well as angina. And most of the nodal tissues like SA node and AV node are calcium dependent and work very well with calcium channel blockers. And coming to the ventricular myocyte, it has its action potential having four phases, 0, 1, 2, 3, and 4. And we see the subsequent correlation with the ECG here. So phase 0 is when there is going to be a rapid sodium influx, with phase 2 having potassium efflux. Phase 2 will have calcium influx and potassium efflux, with phase 3 having a potassium efflux, and phase 4 maintaining the resting membrane potential. So if you see the whole duration of my ventricular events, that is going to correlate with the action potential duration. So here, what are the implications we draw? If I have a drug that is going to block the sodium channel, the QRS is going to widen, like in tricyclic antidepressant poisoning or patients with sodium channel blockers. And importance of phase 2 is whenever I have hypocalcemia, it correlates here with the ST segment here. And ST segment will involve only prolongation of the ST segment is going to be because of hypocalcemia. If I have a potassium imbalance, I will affect both phase 2, 3 as well as 4. Hence, I will affect both my ST segment as well as the T wave. So once we have understood what is really happening at the level of the heart with respect to the ions, let's understand how it is going to be picked up. So we place something called an electrode that can pick up electrical signals in the heart. So where do we place them? So there are two lead placements. So because heart is a three-dimensional structure, we try to get the 360-degree orientation with these leads. So we divide these leads into limb leads and the precordial leads. Precordial leads are going to be placed on the precordium of the heart, and the limb leads are going to be placed in the limbs. So we have 4 right, left, upper limbs and lower limbs, and the correct nomenclature has to be placed. And very, very commonly we have precordial lead displacements that have to be avoided. So V1, V2 are placed parasternally in the 4th intercostal space, V4 in the midclavicular line, and V3 between V2, V4, and V6 in the anterior axillary line in the 5th space, V5 between V4 and V6. So how does this pick up the signal? So whenever there is a positive charge that is going to come towards an electrode, it is going to be showing a positive deflection, and if the positive charge is moving away from an electrode, it is going to show negative deflection. And exact opposite is whenever there is A negative charge going towards an electrode, it is going to be negative, and if a negative charge is going away from an electrode, it is going to be positive. And if the electrode is placed perpendicular to the flow of charge, it is going to be biphasic. So this is the orientation of the leads. So these leads, we can divide them into limb leads and precordial leads. Precordial leads see the transverse section of the heart, and the limb leads are going to see in the coronal plane. So we have this, if you imagine this to be my heart, so this is going to be my apex, and this is going to be my diaphragm. So there are some cameras or leads that are going to see the diaphragmatic surface of the heart. They are termed as inferior leads. There are going to be some leads that are going to see my apex, that is going to be the lateral wall of the heart, so they are called as lateral leads. And there is some lead that is going to be seeing from here, that is called as a forgotten lead or lead AVR. And then there are some leads that are going to see here in the transverse plane, where V5, V6 is placed at the apex. This is going to be my anterior wall seen by V3, V4, and this is going to be my interventricular septum seen by V1 and V2. So whenever we are looking at leads, we look at them together. So these are my inferior leads. These are going to be my lateral leads, and this is going to be my forgotten lead, which is AVR. So whenever I look at ECGs, the paper, we look always towards contiguous. So what do you mean by contiguous leads? They represent the same wall. So 2, 3 AVF together we see, 1 AVR, V5, V6 together, V3, V4 together, V1, V2 together, and AVR at the end. So now we have to interpret any ECG we see, and change in one should be reflected in the other as well usually. So this is about how we look at the ECG. Once we know the ECG, so we'll see how each wave is generated, and let's understand what are the squiggles in the ECG. So the first wave that we are going to get is called as a P wave. So two things, one, it is going to be biphasic in the precordial leads because the electrical impulse is traveling from the right atrium to the left atrium posteriorly, and lead V1 here is going to see this as a negative deflection because it is going away from it. So we get a negative deflection. First is going to be a positive deflection. And coming to the normal P wave in the limb leads, it has two parts. So the first part is going to be represented by the right atrium. The second part is going to be represented by the left atrium. So this will be important in understanding the atrial enlargements. So once we have this, we are going to have the activation of the ventricle, which is going to be having three parts. The initial part is going to be the septal activation. The left to the right side activation is happening because there's the early activation of the septum on the left side by the left septal fascicle, which is absent on the right side. Once we form the Q wave, we are going to get the R wave that is going to activate the major portion of the ventricle here, and then we are going to get an S wave that is going to activate the basal portion of the heart. And this direction is always between the endocardium to the epicardium. So once this is happening simultaneously, the atrium also is going to relax. So that is going to represent a wave called as a tau wave. And how do we name these QRS complexes? The first initial deflection, if it is negative, it's called as a Q. The first positive deflection is termed as an R wave. And the first negative deflection after an R wave is termed as an S wave. And there are going to be capital and small letters that are going to be inscribed based on the relative amplitude of these waves. So pause the video here and try to answer this yourself of all these QRS complex nomenclatures. This is going to be a small q and a big R, QS capitals, big Q's, big R and a small s, small q, big R and a small s, big Q and a small r, capital R and small s, small r, big S, small r, big S and a small r, big R, small s and a R dash, and a small r, big S and a capital R dash. So once we know how the nomenclature is done, let's proceed to the ventricular relaxation called as T wave. So the two things to remember, T wave corresponds to the net QRS amplitude. And how do you define a tall T wave? More than 5 in limb leads and more than 10 in the precordial leads is termed as a tall T wave. Following T wave, sometimes you may get a U wave. That is either because of mid-myocardial cell activation or Purkinje cell repolarization. Best seen in leads V2, V3 normally is less than 25% of the T wave, and it is inversely going to correlate with the heart rate. So whenever you have bradycardia, you can see prominent U waves, or whenever there is electrolyte imbalance, you can see U waves. And inverted U waves are very, very dangerous and represent CAD or coronary artery disease. So So here we have a sinus bradycardia and prominent U waves. Here we have a patient with hypokalemia who has T wave inversions with a prominent U wave. So this is called as a T wave fusion wave, which is seen in hypokalemia, and this is inverted U waves that are seen in coronary artery disease. So once we know what a U is, so we'll see abnormalities of the QRS complex. So pathological Q wave we define as a Q wave more than 0.04 seconds in the duration and more than 25% of the subsequent R wave in amplitude. So we come to the R wave progression. So as we see from the V1 to V6, the R wave gradually increases and the S wave gradually shortens and disappears. So this transition point happens between V3 and V4, and in case it is delayed, then it is called as a poor R wave progression. So technical definition is R wave in V3 less than 3 millimeter. These are the various causes for an R wave progression, poor R wave progression. So once we know each of these waves, so we come to what are interval and what is a segment. Segment is an isoelectric line, and interval contains a complex with a segment. So from the onset of the P to the end of the PR segment, to the end of the PR segment, it's called a PR interval, and this isoelectric line is called the PR segment. This QRS is going to be 3 small boxes, and then the point of S wave and T wave fusion is called as the J point, and from the onset of the Q wave till the end of the T wave is called as the QT interval. And there are two segments, which is the PR here and the ST here segment. ST segment has its own implications in ischemia that will be discussed subsequently. So how do we remember what is the upper limit of all of these? P wave should be less than 2.5 boxes in the limb leads. PR interval 3 to 5 small boxes, QRS less than 3 boxes. The QT interval should be around 8 to 10 boxes, small boxes. The T wave should be less than 5 millimeter and 10 millimeter in the amplitude in the chest and in the precordial and the limb leads, and U wave should be around 1 to 2 millimeter. So why are we so stressing upon the concept of QT? Because there is something called as QT prolongation. So how do we determine that on a normal ECG? Just by the eyeballing method. There are various formulas as well, but commonly used is the eyeballing method. So let's take the RR interval, which represents the ventricular activation time, ventricular regularity or ventricular beating. So if we take the RR interval, draw a line exactly midway between the RR, and this QT or the T wave should end before the midway. So here we see that this is the RR interval and the QT is way crossing the midway line, and that is suggestive of a long QT. So why is long QT important? Because it degenerates into a rhythm called as torsade, which means twisting over a spike, where this happens because of increased calcium influx. And also very important to remember is, as the heart rate reduces, the QT is going to prolong. So to treat this, we give magnesium that blocks calcium, and we maintain a pacing to maintain the heart rate at more than 60 beats per minute, so that the patient doesn't go again into bradycardia and go into a torsade. So these are common drugs that can cause a torsade rhythm. So once we know what are these waves, so let's understand the ECG paper. So the ECG paper has large boxes and small boxes, and it is going to represent amplitude on the y-axis and time on the x-axis. So each large box has 25 small boxes, and each large box is 5 millimeter by 5 millimeter. So each small box is going to be 1 millimeter by 1 millimeter. First point. The second point is the ECG paper moves at 25 millimeter per second, which means that 1 millimeter will be equal to 0.04 seconds. Hence, 1 millimeter is going to represent 0.04 seconds on the x-axis. So once we see this, we look at something called a standardization. So every normal ECG is normally functioned to run at 25 millimeter per second at this paper speed, and 10 millimeter should be representing 1 millivolt. So if the standardization is half, the QRS becomes shorter. If it is doubled, then it becomes longer in amplitude. So here we have this QRS, which are very, very small. That is because of the half standardization. So once we see the standardization, we proceed to how to calculate heart rate. So to calculate heart rate, the first step is look at the rhythm. So if the rhythm is regular, if the RR intervals are regular, you can use the formula called 300 divided by the number of large boxes or the countdown method. If the RR intervals are irregular, so if they are irregular, then we use the 6-second rule or 3-second rule, where we count the number of QRS for 3 seconds and then we multiply that by 20 to get the heart rate. So here we have a person with a sinus bradycardia with heart rate of about 45 to 50 beats per minute. So what is this countdown method? So you just remember these values: 300, 150, 175, 60, 50, 43. So what is the importance is, so you take a QRS on the line here and you place each of these values for each large QRS. And the point where the second QRS or the RR interval arrives, that the number that correlates with the second RR will be the heart rate. So here we see the first RR, the QRS is here, the second QRS is here. And if you place a number 300, 150, 175, 60, so it's going to be 60 here. Here it is 300 and 150. In the 150th place, we have the second RR interval. So this is going to be 300, 150 and 100. So this is the countdown method, very quick and very easy to use. So if it is irregular, we use the number of QRSs in 3 seconds. Here I have 6 QRS in 3 seconds and I multiply it by 20, which is 120 milliseconds, 120 beats per minute. So once we understand that, we'll come to the concept called as axis. So what does axis represent? Axis represents the net direction of ventricular activation. Each wave has its own axis. So P wave has its own axis, QRS has its own axis, T wave has its own axis. But commonly we use the QRS axis. So how to determine that? So we will use this very famous diagram to understand it. So we look at two perpendicular leads, lead 1 and lead AVF. So this is going to be the direction of lead 1. So this is going to be positive. If I change the direction, this is going to be negative of 1. And this is going to be the direction of lead AVF. And if I change the direction, this is going to be minus AVF. So let's take the net QRS in lead 1. So let's use this with an example now. So net QRS in lead 1, let's assume this is lead 1. This is a QRS which is predominantly positive. So it is going to be positive, which means it is going to be either in this quadrant or in this quadrant. The second point is look at AVF. So AVF is going to be positive here. So AVF is positive here. So lead 1 is positive and lead AVF is positive. That means it is going to be in this quadrant. So if the AVF is negative and lead 1 is positive, it's going to be in this quadrant. If it's going to be here, then it's going to be negative in 1 and negative in AVF, which is called an extreme axis. And here it is going to be negative in lead 1 and positive in AVF, it's called as a right axis. So once we see here, this is called as axis. So here we see left axis is beyond minus 30. That means there is a part of the quadrant here that is going to be physiological. So that's why we use the concept of lead 2 for our rescue. So if I have a lead 2 that is going to be more positive, that means the electrical activity should be somewhere here. If the electrical activity is in this direction, the net QRS is here, that means it is going to be away from lead 2 more. So the lead 2, if it is negative, then it is going to be along with lead AVF being negative, then it becomes a pathological left axis. If lead 2 is positive or if it is biphasic, then it is physiological axis. So that is the concept of left axis. Then there are various causes for each of these axes, but how to remember this? So a normal mnemonic we can use as left leaves and right reaches. That means look at the QRS tip. So the tip in 1 and AVF seem to leave each other. So that is left axis. And if they are going to seem to come towards each other, then it is right axis. So lead 1 and lead AVF coming towards each other is called as right axis. These are the various causes for each of these axes, which will be discussed subsequently. So once we look at the axis is done, we look at starting to interpret the ECG. So the first thing is look at standardization. Once we are clear with the standardization, we look at lead AVR, because P wave should be negative in lead AVR and the QRS also, net QRS should most of the time be negative. So in case it is positive, look at the R wave progression across these leads, the precordial leads. If the R wave progression is normal, then there is high chances that there is a left arm, right arm lead reversal. So that is why this is very important, because our interpretation will change in the limb leads, the axis interpretation, everything changes. Whereas precordial leads are untouched by it. So how do we start interpreting an ECG? So look at standardization and the technical details first. The second, look at the rhythm, then the rate, the intervals, the axis, the chamber enlargement, the QRST changes, and look for blocks or ischemia. You can use any approach. This is the approach that we use personally. But make sure that you have an approach and stick to it always whenever you're interpreting any ECG. So these are some of the ECGs we'll see. We'll solve it together. So we have, assuming this is a normal standardization, we have a normal sinus rhythm defined by positive P in lead 2, negative in AVR, positive in 1 and AVL as well, and with a negative QRS. So it's a normal sinus rhythm. It appears regular. The heart rate is about 75 beats per minute. Then coming to the intervals seem normal. The PR is normal. The QT is about 10, so it is normal. Coming to the axis, so 1 is positive and AVF is negative. So lead 1 is positive and AVF is negative. That means it is here, and then it is going to be in this quadrant. 1 is positive, AVF is negative, and then lead 2 is again negative. So that means it's in this direction. So that means it is a pathological left axis. So coming here, assuming the standardization is normal, the rhythm here is irregular, and we don't see clear-cut P waves. So the second point is there is no then the rhythm is very irregular. Once we look at that, we look at the intervals cannot be clearly defined here. Then we look at the axis. So lead 1 is negative, lead AVF is negative. So it is an extreme axis deviation. So once we have an extreme axis, apart from that, we look at the chamber enlargements, which will be discussed subsequently. Then we look at QRST changes. So look here, there is a wide QRS. The QRS is wide, more than 120 milliseconds. Then the QRS here is also wide. Here the nomenclature would be RSR dash with a wide S wave in 1 and V6, which qualifies for a right bundle branch block with an irregular RR interval. So this patient has a right bundle branch block with an atrial fibrillation in the background because of irregular RR intervals with absent P waves. So coming to this ECG. So this is ECG of a person who has a normal standardization with normal sinus rhythm with AVR negative, lead 2 positive. Then we look at the heart rate, it is about 300, 150, 100. So it's more than 100. So this is a sinus tachycardia. So once we have sinus tachycardia, so let's look at the intervals. So the PR interval appears normal. The QT intervals, we have to calculate the corrected QT. So here it appears normal. Then we look at the axis. So lead 1 is positive, lead AVF is negative. That means it is going to be in the top quadrant here. And lead 2 is biphasic. That means it's a physiological left axis deviation. So coming to this ECG, assuming a normal standardization and a normal paper speed, we look at this ECG. So we see a tachycardia. The heart rate is regular. The QRS is wide. We don't see clear-cut P waves. The AVR is positive. And coming to the axis, so lead 1 is negative, lead AVF is negative. So it's an extreme axis deviation without any P waves. So a very important clue is you have to look for the P wave in the T wave. So here we can see some small blip here, which is probably a P wave. There is one more here that is probably a P wave. If you trace it down here, it looks like a P wave here as well. So this is a wide QRS tachycardia with a positive AVR and an extreme axis suggestive of a ventricular tachycardia. So coming to this ECG, very interesting ECG. So we have a normal standardization, normal paper speed. So then the second thing is to look at lead 2 and AVR. So it is normal sinus in origin. So once we know it is sinus, we look at the heart rate. So 300, 150, 175. So somewhere around 75 beats per minute, 70 to 75 beats per minute. Then it is regular, so it is 75. Once we know it is regular, so we look at the axis. So lead 1 is positive, lead AVF is also positive. So it is a normal axis. So then we'll come to the intervals. So P, QRST intervals. So you look here. So PR intervals looks a little prolonged, borderline prolongation of the PR interval. So the QRS appears normal. There's a wide S wave here in lead 1 and lead V6. Then you look at the RS R dash pattern, small r, small s, and a big R prime here in V1 with some T wave inversions here. So once we finish that, the axis is normal. So this is suggestive of a right bundle branch block that we will see subsequently. And very, very important is look at the T wave. So the T wave here is almost equal to the height of the R wave. Here also you see the R wave and the T wave look equal. And here you see in the precordial leads, they appear somewhat pointed. Here in V3, V4, V5, the T wave is appearing pointed. So whenever we have a pointed T wave, tall tinted T wave with the widening of the PR interval, it is classically suggestive of a hyperkalemia. Although this ECG may just be innocuous right bundle branch block, but there is an underlying hyperkalemia that is hiding. And hyperkalemia is known to be a mimicker of everything possible on the ECG. That is why hyperkalemia is very, very important to pick up on the ECG. So this is a short summary of what we have learned. So for any queries or feedback, feel free to email us at this website, at this email. And if you have any interesting ECGs that for discussion, feel free to email them and we'll take them at the end of the sessions. Hope this venture is useful and enjoyable for everyone. Thank you.